సో చుట్టాలు కానీ లేదంటే ఆఖరికి still has 5 more minutes.
So I think Surin was just asking if we can maybe just talk about the timing issue maybe before we start the presentation.
But I see like a couple of participants have already joined. So do you think we'll do it now or
Or I think we could do it with the participants on too, because
Okay.
it's good for them to have some of their input.
Sure, no problem. Do you want me to stop the screen share?
It's okay. Or
Okay.
Surin, what do you think? Is it good to talk about the timing of sessions to start with everybody online, or? Well, I see Surin's there, but I'm not sure that we can hear him.
Yeah, Jonathan, I'm sorry. I was just muted.
Oh, no problem.
Yeah, that's good idea, and that's why I also want to join and listen a couple of your talks, and then I tried to get this full result from Krishna, but still I'm waiting for his thing. He said that he will get back to me before the meeting. Still, I didn't get that. I'm waiting.
Okay.
Because then here is a COVID situation is getting worse, and then all the medical officers expected to run all additional centers and treatment places. So then all are busy, not like that when we were starting. Now is lockdown today,
I see.
for this week. So
Things are getting busier.
yeah, it's getting busier. Then they need to. They are running like intermediate care centers, and we are opening new intermediate care centers for this COVID management for all the symptomatic patients. And then the hospitals, they are opening the new wards for the ICUs and high dependency units in the hospitals with these oxygen things. So then.
I'm sorry to hear that. That sounds very stressful.
And that's why both was stressful for doctors and nurses and
Yeah. I guess one thing we could think about as well, Surin, is if people were feeling too overwhelmed.
I'm with Jonathan. Then before he start the thing, okay. So I'm sorry, Jonathan. I was talking to Krishna Kumar and about.
Oh, no problem.
Yeah.
Do you need to speak with them about things, or?
Yeah, we will start, and Krishna Kumar also will give his thing. He said that in 5 minutes time he will give the.
Okay. Thing. Okay. I was just saying one other possibility we could think about is whether people would want to just delay some of these sessions for a few weeks or something until the COVID situation is a little bit more under control, maybe, but I'm not sure what you think is best.
That actually my projection, if I'm correct, and they maybe get some vaccines in pipeline, that maybe in a month or two, and then after these people start, that will go for another 4 months or something. So then this will continue like this, then after going to the things that curve actually started to steepening up after the April 14th, somewhere in April 20th. So now it's now moving to the peak, maybe mid of June. Then then it will take time to come down. Then maybe So then maybe it's good to have at least continue like if they are all available for Saturdays. So at least one session. Otherwise, that people will also we will lose the interest and
interest. Yeah.
that also I'm worried.
Well,
So we will.
that's another option. I guess we could change it to once a week for a longer
Mm.
period of time, and then they're not
Yeah.
so.
When things are improving, then we can again
Yeah.
quickly switch to some of them.
Yeah. I see lots of people joining. That's good.
Mhm.
Good evening.
Sir, it's 7:31. Usually, like when it's the time, and we wait for another 2 to 3 minutes for more participants to join, and then we'll start the introductions, sir. Hope it's all right.
Okay. That's good, Vanilla. Yeah. And just to be, so I guess we all start together, and then do you break us up into
Yes.
the physicians and nurses
Yes.
rooms? Okay.
Yeah.
That's great.
So hosts and co-hosts will have the option to move yourself directly in whichever room you want. So the rooms are assigned into doctors and nurses. So you'll
Okay.
directly go into the doctor's room, sir. And we have nurse faculty, and Stella madam has already joined. So she's Miss Stella, sir. Stella ma'am, good evening.
Good evening, Vanilla. Sorry, I was in another session which started since morning. I'm doing one or the other session.
No problem, ma'am. Thank you so much for joining
Just
in
I
time.
finished and I joined here.
Yeah.
Good evening. This is Dr. Suren from Sri Lanka. So Vinila, thank you for that raising that time issues, and we are discussing. And then actually, I was in Calicut. Actually, Stella is in Calicut, no? Is she from
Calicut. Yeah, Calicut. Yeah, Calicut.
Yeah, I was in 2015. I was getting training, that certificate course in Calicut.
So you have met me?
Yeah, I met you. Yeah, I met you.
Yeah. Okay.
I was,
I
was listening a couple of your lectures.
Yeah, I am the same Stella only. Now
Ah.
I'm retired. I got retired
Alright.
last year.
All right. But you are not practicing at the moment.
Yeah, no, not going to the hospitals. Online and offline sessions are there for me. Yeah, online, offline session. Actually, I joined in the thought of going also, but it's really what to say. You know the COVID problems over here.
Yeah.
And I have elderly people also at home.
So you are in Calicut or Delhi?
Yeah, no. Now I'm in Calicut only. But last 2 months I was out. I went to Bangalore and all to deliver some sessions, and I came back. Of course, daily I have online sessions. At least 1 or 2 sessions daily I'm taking.
Recall, and you were working, no, somewhere in northern part also. No?
Yeah. I used to. Yeah. I keep moving to the places, but after 20, this one COVID first wave, I have not moved anywhere except for this March and April. Of course, I went to Andhra and Bangalore.
Okay, Jonathan. Sorry, Jonathan. Yeah, for the cross meetings. Sorry.
No problem.
So we will start off or what?
I think, yeah. I think we should start off.
Okay.
Suren sir, today it's you want to start off or please.
And that as usual you start in introduction.
Sure.
So I'm Dr. Suren, actually attached to Faculty of Medicine, Department of Community and Family Medicine, Faculty of Medicine, University of Yafna. And my interest in palliation since 2013, I was attending one of the workshops conducted by Dr. Suresh Kumar, organized by the Jaffna Medical Association, and then I'm part of now Northern Palliative Initiative with Dual Cancer Collaboration and Hyderabad team with the Northern Province. Thank you.
So, very good evening, one and all. My name is Vanilla. I work as a program coordinator at Hyderabad Center for Palliative Care. So once again, thank you so much for joining this evening. We have a very excellent didactic sessions by Dr. Jonathan and Ms. Stella. So Zoom etiquette, which I wanted to tell before we break out into rooms. And please rename yourself. If you can't rename yourself, please put your name in the chat so that we will rename you, because it's very important for your attendance. And please make sure that whenever you are speaking, please unmute, speak. And then if you're not speaking, please mute your microphone. And once again, a humble request to everyone, please keep your video cameras on throughout the sessions. It's very, very important, because this is an online course and we want so much kind of interaction between the faculty and the participants. So request all of you turn on your cameras throughout the session. In between, yes, for a minute or two, you can still turn off your cameras and just go and come back, but we want your cameras to be on throughout the sessions. And if you have any questions during the session, please type down your questions in the chat and we will read out the questions for you for the faculty. So, sir, Suren, sir, I'm just going to request you to introduce Dr. Jonathan.
Thank you so much, Vinila. I'm delighted to introduce Dr. Jonathan Pierce. He's one of the primary care physician and expert in palliative care and practicing in British Columbia, Vancouver, and he is part of this Two World Cancer Collaboration. The Two World Cancer Collaboration is a Canadian-based charity, and they are particularly working developing cancer control-related activities, especially the palliative care. So Jonathan actually came with his wife and with other team members in 2017 to work on this palliative care initiative. Then after their visit, and we are able to send two doctors, Dr. Madhuragan and Dr. Kausigan, and also two nursing officers to Hyderabad, and then we are able to train them. And at the moment, with their support, and we are able to run the home-based palliative care in Jaffna and Bonia district. So then Jonathan, since then, he's really helping us to run. Even this local team, they get instant support then whenever they need, and through the WhatsApp. They provide their expertise to provide comprehensive palliative care in the ground, and also he is the key, and then actually runs that monthly case discussion, particularly that are also very useful, and I think that for the future our team members also will enjoy that thing. Jonathan is a very good teacher and then interested in palliative care. I think that we are very proud and delighted to have him here to teach you. Thank you. Jonathan, this is for your time. Then before that, the Krishna Kumar called me. I will talk to him, and then within 5 or 10 minutes, then if we can get their opinion of this, having these classes, and then after that, is it okay to start, or what do you think?
Maybe we should just get started, and then it's
Okay.
I just see Krishna was texting some of the responses from the survey. Maybe, Suren, we should just take some of these responses from the survey, and then we can have our own little discussion as a faculty about the timing of things. It might be more efficient than trying to have so many participants. Maybe I'll plan to just email you after this session, and we can figure it out. That work?
All right. Okay, that's fine.
Yeah, for the others, who do not know, I think most of the nurses and the faculty have met Stella Madam. Stella Madam is one of the very senior most nursing faculty. I think Madam has more than 35 years of teaching experience, and Madam is a nurse practitioner whom most of you have met, and we have shared a brief biodata also of Madams. Thank you so much, Ma'am, for coming here to teach our participants. So I'm going to break out into rooms now. Thank you. Are you
Sorry,
going to
it's
start
just
your screen share, sir?
there we go. Yeah, I'm just my computer was having a little bit of a problem here with
Shall I do it
sharing.
for you, sir?
I think we should be good now.
Oh, yeah.
You guys can see that?
Yes. Yes.
Okay.
Yes, sir. Please go ahead.
Okay. So that's that. Are you able to see the dyspnea slides, or is it just the delirium slides?
We are seeing delirium slides, sir.
Yeah, delirium. Right, yeah.
Okay. Um, okay. Well, we can start with delirium. Sure, that's fine. I don't know why it's not letting me share the dyspnea, but we'll figure that out in a minute.
Can we make it full screen, sir?
Oh, there we go. There's dyspnea. Okay. Sorry, my computer was just acting
No,
up.
it's okay, Jonathan. Now we are seeing the dyspnea, but the slides are not.
Yeah. Can we make it full
Oh.
screen, sir?
Yes.
Yeah.
Okay. There we go.
Yes. Thank you,
They
sir.
can see. Okay.
Thank you.
Good. Well, glad to be able to join you all today, and we'll try to make things interactive so we can ask questions and have some time for questions at the end about some of your challenges with managing these topics. So we're talking about dyspnea and delirium today, which are two extremely common symptoms to see in patients with advanced cancer or advanced disease generally, and very common for them to experience as they go through their illness experience, but also very close to end of life. And we can talk about some of the differences in management as they move through. So in terms of an overview, we'll be talking about some of the epidemiology of dyspnea and the root causes of dyspnea, and then thinking about management options in terms of non-pharmacological management and medications, and then pleural effusions. Dyspnea comes from the Greek language, and it's quite simple origins. Dys meaning difficult and pneuma meaning breath, so difficult breath. And we know it's very common at the end of life. Only 11% of patients
Sir, sorry,
reported
may I
feeling no
interrupt you?
breathlessness.
Sir, may I interrupt you? Sorry, we are not able to see your slides.
Yeah.
We can't see your slides.
Oh. Okay, that's strange.
Shall I share them, sir, meanwhile?
Okay.
Yeah. We
Can you
can
see them now?
Yes.
Yeah, we can see that. Yeah, but not in full. Okay.
Okay. Are they clear now?
Yeah, that's perfect.
Yeah. Okay. Okay. So also very common in a lot of the common diseases that people face in terms of life-limiting illnesses. Cancer, heart failure, and chronic lung disease are the top causes of mortality in the US and around the world. In terms of thinking about what dyspnea is, it's a very subjective experience, and I think that's important to remember. Sometimes patients can appear to be very short of breath, but they actually don't feel particularly short of breath, and it's kind of their normal baseline. Sometimes people can appear very comfortable and calm, but they actually are experiencing a lot of distress. So it's always important to ask the patient what they're feeling. Patients use a variety of words to describe what dyspnea is. Can describe it as air hunger or increased effort of breathing, chest tightness, rapid breathing, feeling of suffocation. All those are types of words that people use. We know that dyspnea has a huge effect on people's quality of life, and objective measurements like the FEV1. I don't know if you're all familiar with that term. always want to make sure I'm trying to use terms that people recognize, and some of them are different in different countries, but the forced expired vital capacity in 1 second, the was related to health-related quality of life. Also, people that have other anxiety or panic disorders have often an intensified experience of dyspnea. So it's important to know about this association with kind of mental health concerns and the experience of dyspnea. And also people that experience dyspnea over a long period of time have higher rates of depression. We know dyspnea is very related to prognosis, which makes sense. People that are more short of breath are likely closer to end of life. It's a part of many prognostic scores that we use in palliative care. So the palliative prognostic score or the palliative prognostic index, and also in disease-specific scores, there's something called the Bode scale in COPD, and in heart failure, the New York Heart Association class is mainly based on sense of dyspnea. In terms of understanding what actually causes the experience of people feeling dyspnea, we usually think of several mechanisms, 3 main pathways for this. The first being that people need to generate an increased respiratory effort in order to be able to breathe. So this is usually some sort of an obstructive pathology like COPD, where the airways become very obstructive to flow, or mass lesions such as cancers that compress the airways. The second category being where people need to use a more higher proportion of their respiratory muscles. And this is seen in places like advanced cancer cachexia, and very common in patients with ALS or other neuromuscular disorders, where it's really just their respiratory muscles that are becoming so weak, it's difficult for them to generate the same ventilation output that they normally would. And then lastly, sometimes we can have cases where people's ventilation requirements are increased. And so this is seen in times of fever or in anemia, things of that nature. So we think of dyspnea as a mismatch between what the brain thinks that it needs to breathe and what the actual output of breathing can be. So we call this a mismatch of respiratory afferent and efferent signals from the brain. And we have some evidence and thought that the opioids that are within our bodies naturally, endogenous opioids, are thought to lessen this effect of dyspnea on the brain. And so that's led to lots of study and interest around how opioids may help with relieving the sensation of dyspnea for people that have ongoing dyspnea despite treatment of their underlying medical issues. So we want to talk about a case as we go through today as well, and we'll get your guys' thoughts and questions and comments around Mr. A. So he's a 69-year-old man, long-standing smoker, over 30 pack years. He has known COPD following this, but he's been fairly stable on an ipratropium inhaler, which is an anticholinergic inhaler, and with few recent exacerbations. But he's noted to be more short of breath over the last couple of months, and he's starting to lose weight. He's lost about 10 pounds. He goes in for a chest x-ray and he finds a right upper lobe mass, and the CT scan done after that indicates that it's likely a lung cancer with some liver metastases. And he goes on to have a biopsy that confirms an adenocarcinoma. He's seen by his oncologist and given some radiotherapy for the mass to try to help with symptomatic relief in the chest, and both relief of pain and relief of potential dyspnea. He declines going through with any other chemotherapy because he's quite concerned about side effects, and he does understand the progressive and incurable nature of his malignancy, but he wants to maximize his quality of life. And he does okay after the radiation, but a couple months later you're seeing him again, and he comes into your clinic and he's having quite a bit more shortness of breath. What would be kind of going through your mind at this point around causes for his dyspnea? You're seeing him in clinic now. So he's a man with known COPD, fairly new diagnosis of cancer, had some radiation. Any thoughts?
Maybe due to the radiation, or maybe due to increase in size of the tumor.
Yeah, those are very good thoughts. So post-radiation pneumonitis, and certainly progression of tumor. Any other common causes for somebody like this?
There's
Maybe
a message in the
exacerbation.
chat, sir. There's a message in the chat saying pleural effusion.
Pleural effusion, yeah, that's a very important consideration in somebody with malignancy. Anything else?
Co-pulmonale and cardiac failure. Cardiac failure.
Yeah. Any particular causes of cardiac failure that might be more common in a patient with cancer or cor pulmonale?
And cardiac failure.
And a more acute causes? Yeah. What other common acute complication in patients with cancer do we see with respiratory effects?
Anxiety. The anxiety.
Anxiety, that's definitely possible. Yeah. But I was also just thinking of a pulmonary embolism. So in anybody with cancer, you always have to, and they come with increasing shortness of breath. I think it's always important that you convince yourself that they're not having a pulmonary embolism, because it's certainly can be a common presentation. But no, that's good. I think you hit on most of the points. So certainly the cancer itself, either cancer itself or the treatment of the cancer, as was mentioned, radiation pneumonitis, could be having just a regular exacerbation of his pneumonia or COPD. And then PE is a very important thing to rule out as well. So we'll come back to Mr. A in a little bit and work through him a bit more, but I want to just also talk about other ways that we approach dyspnea and think about dyspnea in palliative care. So obviously there's the medical reasons for people feeling shortness of breath, but as was just mentioned, things like anxiety and psychological effects can have a huge impact on people's symptoms. And dyspnea is a very primary kind of sensation for us. So it's very related to things like anxiety, and it's a symptom of panic attacks, and important to assess whether there's some underlying psychiatric issues going on. I had a patient this week on the palliative care unit, and she had multiple medical complications, DVTs, and pneumonitis after some immunotherapy and all these types of things. And she was feeling kind of acute onset of shortness of breath. I was quite worried about her, and doing CT scans and things like that, and it ended up being, in the end, what seemed more like a panic attack than any other physiological acute cause. So it's always important to keep on our mind. We think about this idea of total dyspnea, and I think in some of your pain lectures you talked about the idea of total pain, where it's not just the physical experience of the pain and the physical causes of the pain, but the whole patient experience that goes into the symptoms. So we think about the 4 different spheres of people's experience: physical, psychological, spiritual, and social. So it's important to consider this whenever you're seeing a patient with dyspnea, and particularly towards very end of life. Dyspnea can be very associated with existential distress and panicking about suffocating near the end of life and that sort of thing. So helping patients to be calm and supported in those situations is very important. In terms of thinking about some interventions for dyspnea, we can start with the non-medication interventions. So there's things like pulmonary rehabilitation that's often used in diseases like COPD. And this helps with people being able to breathe more efficiently, basically, and being taught how to conserve their breath in different activities and not tire themselves out so much with just the process of breathing, and to strengthen some of their respiratory muscles. There's been some research and interest in using fans for dyspnea, and this is the idea of air kind of blowing over the face and into the nasal passages. It seems to stimulate the trigeminal nerve in a way that feeds back into the breathing centers and helps with the management of dyspnea. So very simple things like a fan, patient can control themselves, or just a fan in the room, or simple things like opening the window with a breeze blowing in from outside and things like that. It sounds very basic, but it actually can have quite a benefit for patients, and there is some research to back that up. Chest wall vibration is used in some cases. This is usually more for helping try to clear secretions that are very thick or difficult for patients to clear. There's some interest in acupuncture and oxygen therapy. We'll talk a little bit more about later. Certainly can be helpful for people that are hypoxic. And then there's some debate about for people that are not hypoxic. And the other important thing to advise patients around is activity pacing and modification, and trying to help them set realistic goals about what they can and can do and what might be too much exertion for them. So coaching around that can be helpful. And then radiation therapy, certainly in some settings of cancer, can be quite beneficial. In terms of looking a little bit more at oxygen, we have pretty good evidence for using oxygen in hypoxic COPD patients, which makes sense. People with oxygen are low, and you give them oxygen, they feel better and they live longer and do better. So that's been very well established. COPD patients with incident hypoxemia, so that's basically their oxygen levels go down with some sort of activity or walking or something like that, and they are also improved with use of oxygen. So we certainly would always use oxygen for patients that are hypoxemic. I think the more interesting question is for patients that have normal oxygen levels, how do we manage those? And there was one study, it's quite famous in palliative care, from Amy Abernethy, and she took a few hundred patients with a variety of diagnoses, COPD and cancer, and they had normal oxygen levels, and then they were feeling quite dyspneic despite other treatments, and she gave some of them oxygen and she gave some of them just regular medical air, and all of them showed some improvement in their dyspnea. So there wasn't a placebo control in that study, but it was just more of a hypothesis around this idea of air kind of blowing over the nasal passages and helping with the sensation of dyspnea. So a lot of patients, if their oxygen levels are normal and you give them a small amount of oxygen, they may report feeling better. But the other thing you can try is using fans, or sometimes, I mean, we don't really use medical air much in terms of nasal prongs, but that is a potential option if they find it beneficial. The only caution, I guess I would say, is for people with normal oxygen levels. If they do have COPD, then you just have to kind of make sure their oxygen isn't getting too high to the point that they're retaining CO2 and causing other problems there. So for patients with kind of low normal oxygen levels, sometimes we do a trial of oxygen, and the patients can decide if they feel benefit from it. But if they don't feel benefit, then it should be stopped. The other mainstay of treatment for dyspnea that's refractory to treating the underlying cause. I mean, I guess I should preface all of this talk by saying with dyspnea, like with many symptoms in palliative care, we obviously try to treat the underlying cause as much as possible. And then, often patients with advanced disease, they still do have residual symptoms. So that's really what we're trying to help manage here. So opioids are most studied pharmacological intervention for management of refractory dyspnea, and morphine would be the most commonly studied opioid. And there's been multiple systematic reviews that there is a good body of evidence to support the use of opioids, except via the nebulized route, which we don't have very good evidence for. It's growing adaptation as well in the recommendation of several major medical bodies, cardiac societies and respirology societies, in terms of the management of advanced heart failure and lung disease. So certainly growing in use for end-stage illness. In terms of looking at some of the opioid efficacy and what kind of doses people might need, it's been found that generally dyspnea is a little bit more responsive to opioids than things like pain. So we often need even lower doses to manage dyspnea than we do with pain. Now, some patients were managing both of these symptoms with opioids. There's a really good study from Kuro in Australia, who's a really preeminent palliative care researcher, and he looked at outpatients and started them just on a fairly gentle dose of long-acting morphine. And if they didn't have at least a 10% improvement in their dyspnea score, then he titrated them up kind of to the next tier of dose. But over about 2/3 of patients actually benefited from opioids. And of those, about 2/3 benefited even from the low dose of 10 milligrams. So it was quite effective even at fairly low doses. There's been some concern around respiratory depression with using opioids in people with advanced respiratory disease, understandably. We do know that opioids do decrease respiratory rates and can decrease ventilation. But in some of these studies looking at morphine and hydromorphone from Clemens, they noticed that there was significant decrease in dyspnea scores and the respiratory rate, but that the oxygen saturations and carbon dioxide and pulse rate were quite stable. So they concluded from this that if carefully and properly titrated, that opioids can be used safely while avoiding significant negative effects. So back to our case study. So he comes into your office after a couple months after radiation. He's feeling more short of breath. You want to do some investigations to figure out what the cause of his shortness of breath is. You do a chest x-ray and it shows progression of his lung mass. You think that opioids might be helpful for his dyspnea. How would you go about prescribing these? What opioid might you choose? What dose? What would you tell the patient? Anybody have any ideas? Don't all speak at once. Anybody? Any ideas are good.
Maybe morphine. We can start with morphine with a small dose and then increase the dose. And we can advise the
Yeah.
patient, like if there's any difference, like if he's feeling more shortness of breath, then he might have to come back.
Yeah. What kind of dose of morphine would you think about starting for somebody like this? Okay, well, if there's no volunteers, I guess I'll have to start calling out people's names. Let me see here. Maybe Dr. Vithurin, do you have any ideas?
5 to 10 milligram.
5 to 10 milligrams. Okay, yeah, that's often reasonable starting dose. How frequently would you dose it? Would you dose it regularly, or would you just give it as needed, or how frequently would you tell the patient to take it?
Maybe we can start with a BD dose and then increase up to 6 hourly if necessary.
Okay, yeah, that's so you obviously have to kind of know the patient and know how reliable they are, whether they have family members around to report side effects or things like that. If they're, I think 5 to 10, or sometimes even lower doses like 2.5 to 5 milligrams. Morphine's fairly short acting, so like it probably lasts maybe 4 to 6 hours. So usually we would dose it like 4 times a day to start. And then if he's having dyspnea with certain activities or something like that, then he can certainly take extra doses as needed throughout the day. And often in palliative care, we think about dosing opioids via the oral route as needed, even up to every hour, because the peak of effect usually from the oral route should be within around an hour. If you're really worried about delayed transit time or something like that, you could sometimes stretch it out to 2 hours. But if people are still feeling short of breath, even at the peak of effect, then they can safely take another dose to manage their symptoms. So, but again, with dyspnea, often even lower doses of opioids than for pain can be quite helpful. often we do start with a short-acting version of an opioid just to see how people tolerate it. And then once we get them on kind of more of a stable dose and see what kind of dose they're needing to manage their symptoms, then we would think about switching over to a longer acting type of formulation, like a slow release morphine. It's just more practical to take a medication a couple times a day rather than 4 or 6 times a day. And then they can still use the short acting dose as needed if they're having breakthrough symptoms. So I think it's important to remember that a lot like pain management, there is kind of this baseline and continuous symptom of dyspnea, and then there's the incident or activity component of dyspnea, and sometimes they need slightly different medications or timing of medications to manage things. So like we talked about, once the effective opioid dose is found to control the baseline symptoms, then we can often switch to a longer acting formulation, short acting opioids to help them manage breakthrough dyspnea. Because if we just keep titrating up the long acting opioids to be able to cover these incident episodes, then you're going to run into side effects of opioids and people aren't going to be able to tolerate it. So and then anybody that we're starting on opioids, it's a good idea to start them on some bowel medications just to prevent constipation, and tell them to monitor for that. So you get him on some morphine and he's improved with even just a fairly low dose of 10 milligrams sustained release twice a day, and he uses the short acting dose once or twice a day for certain activities. Then you see him again a couple weeks later and his dyspnea is getting worse again, and you examine him and he's got decreased breath sounds and dullness to percussion in the right lower bass. What's this concerning for, and how will you manage this?
Could be a fusion.
Yeah, so it's very consistent with the pleural effusion. What are your options for managing pleural effusions where you work?
So IC tube, we have to intercostal tube. We have to insert the intercostal IC tube.
So chest tube, yeah. So you can do a chest tube. You can do just a kind of one-time thoracentesis and drain off some fluid. What are the potential complications of thoracentesis in a patient like this?
Infection risk, we should start some IV antibiotics or something.
Yeah, so you can get a infection, like can be a serious infection like an empyema or something. Anything else? What are other complications of draining effusions? So whenever you stick a needle into the chest, you have the potential to introduce air into the pleural space, so you can get pneumothorax. And the other challenge can be if you drain the effusion too quickly, you can get sometimes it's called re-expansion pulmonary edema. I don't know if anybody's ever seen that before. It's not too common, but it's a theoretical risk. It's usually draining large volumes very quickly, like maybe over a liter or something from the chest, which is can be quite a bit to drain. So those are all really good options. I think this is his first presentation of a pleural effusion. So usually we would start with either thoracentesis or a short-term chest tube. The challenge with chest tubes in patients with cancer is that the cause of their effusion is not going away. So it's a little bit different than like a parapneumonic effusion or effusion from heart failure or something where you're trying to control the heart failure exacerbation. So we do start to think about more permanent solutions or longer term solutions for patients with cancer. And I'm not sure what might be available in your local settings. Are things like pleurodesis available at all where you work, or anybody seen that before? Or people know what pleurodesis is? Any yes, no, maybe so? Maybe Dr. Puvakaran, have you ever heard of pleurodesis before? Oh. Everybody's muted.
No.
No, okay. Okay, well, I won't spend much time on this then. So pleurodesis is where there's basically a substance that creates a bit of inflammation in the lung, and then in the lung lining, and then it tries to help adhere the lung back to the pleura so that it prevents the reaccumulation of the effusion. And then there are also options of having longer term indwelling pleural catheters that actually, it's basically like a chest tube that just stays in place permanently, and then patients can get them drained as needed moving forward. So those are options for patients with cancer, but sometimes they're not available in all centers. But you're very right. Draining his effusion certainly might help him feel better. And if there's not options of more permanent drainage solutions, then sometimes recurrent drainage of the effusion is possible. What's a complication of draining a effusion many times? So let's say you drain it 1 week and then it comes back a couple weeks later, and you try to drain it again and keeps coming back every few weeks. What complications can you run into? I mean, we talked about the initial ones.
Yeah.
I guess what happens to the effusion or pleural space when you keep draining it multiple times? Anybody seen that before? So you can get loculations or pockets of fluid that accumulate. So then it starts to become very difficult to continue to drain. So over time, continuing to drain things can become more complicated. Okay, well, let's carry on with Mr. A. So another month passes and he's initially helped by draining his effusion and your morphine prescription for him. However, he's continuing to decline and he's losing weight, and then he presents to you with some increasing right chest pain, and his oxygen saturations are going down, and he's a bit tachycardic. And you do a CT scan that shows no pulmonary embolus, but it shows some evidence of lymphangitic carcinomatosis. What is lymphangitic carcinomatosis? Have you seen patients with lymphangitic carcinomatosis in their lungs? Is this a diagnosis you're familiar with, or? Maybe. It's a very quiet group today. So let's see, maybe Dr. Thusis Pavan? Do you have any ideas? What is lymphangitic carcinomatosis? Or maybe there's a different name for it in that I don't know of.
Yes, infiltrating the higher lymph nodes in the lungs and surroundings.
Yeah. So it's where the cancer starts to infiltrate through the lymphatic system, and it's not mass like per se, but it's very infiltrative, and it's a very poor prognostic sign in patients with either primary lung cancer or patients with metastatic disease that's gone to the lung. The treatment options for it are limited. It depends a little bit on what the underlying cancer is and how responsive it might be to further treatment. So sometimes chemotherapy can be considered. But in the palliative care setting, we certainly do use steroids. So often things like dexamethasone, which is not a lot of evidence for, but certainly from experience and anecdotal reports, it can be very effective, at least for a short period of time, like a matter of weeks, to help people with their dyspnea. And then if there is a component of edema or volume overload, sometimes the cancer creates an inflammatory response and causes some other edema in the lung parenchyma. Then sometimes diuresing people can be helpful too. So you prescribe him some dexamethasone, you get him started on some oxygen because he's hypoxic, and titrate up his morphine, and he's able to be discharged home after a few days in hospital, and he has very supportive family. However, you really expect that he's getting towards the end of his life now, and probably in the last weeks of his life, and you speak with him about this, and he's quite open with you that he is not really afraid of being dead, but he's really afraid of the dying process, and he's really afraid that he's going to suffocate at the very end of his life. How would you respond to his fears in that moment?
Asking some open questions about the anxiety.
Some open questions? Okay, what kind of open questions would you think about?
Why you feel so that you will get this type of problem?
Yeah. Maybe he's seen a family member die and it was a very traumatic experience for him. Let's see here, who else? Dr. Sakthabalan? Sorry, I'm very bad at pronouncing your names.
So requesting all the participants to please give your inputs and interact with the faculty.
How about Dr. Jay Arasa? You deal with a lot of patients with anxiety, and I know we always call on you for anything psychiatrically related, but how would you respond to this person's distress?
We need to assess him on the basis of anxiety and some to assess whether the patient is depressed or not also. and mostly we have to ask him. We have to have a meeting, and we have to assess him whether really what we have to talk further, and we have to get why he's seriously worrying about. Actually, is even though he's telling that he's not worried about dying, he's not worrying about dying, but we need to talk with him, and we need to explain him, and if he's actually anxious, we need to prescribe some anxiolytic also.
I mean, I think this is a very understandable fear for him, and it actually is a possible thing that could happen in terms of him having, very significant dyspnea as he gets very close to the end of life. So it's a common thing for people to express when they have very advanced lung disease from whatever source, whether it's heart failure or COPD, cancer, things like that. So I think acknowledging that, he's anxious is important. But I think we can be very reassuring to him that no matter what happens, we can help him to be comfortable and to alleviate suffering for him. And we can continue to be titrating up some of his medications. And then at the very end of life, if he's still feeling very short of breath, then we can help him to be really asleep for the last hours to days of his life if he's really in a lot of respiratory distress. So we'll get to the option of that in a moment. But it's important to reassure patients that no matter what occurs for them, and we can't predict their course exactly, reassuring them that we'll be with them and that we can manage their suffering and distress no matter what happens, and help them to be comfortable is important for people. So that is what happens to him. He goes home for a few days, but he returns to the hospital, and he's having significantly increasing shortness of breath and no reversible causes. And we continue to escalate up his morphine, and we switch it to injectable subcutaneous route. But he's just ongoing in a lot of distress from his progressive lung cancer. He's starting to get confused. He's getting twitchy and myoclonic from the opioids, and probably from hypoxia and hypercarbia. So he's dying at this point. What would you consider? How would you manage this situation? Anybody encountered a situation like this where a patient is dying in acute distress?
Continuous oxygen support.
So we could continue with oxygen, yeah, but even with oxygen, he's gasping for air, and he's agitated, and his family's there, and they're very distressed.
Suck
Any
out
other ideas?
secretions if there's.
What was that? Sorry, I didn't quite catch that.
Suck out secretions from the mouth and oral.
Suck out secretions from the mouth. Okay, and maybe using some medications to help with secretions. Yeah, if he's got a lot of secretions in the mouth itself, then that can be helpful to suck things out. Sometimes the secretions are a little bit lower down, or it's difficult to really suck them out with suction. But I think the other thing in this kind of situation, I mean, he's very imminently near the end of life. And so using medications to help him to be more asleep and more sedated would be very appropriate to alleviate his suffering. So there's a concept called palliative sedation, where patients that are experiencing symptoms that are refractory to all other treatments, and that they have a very limited prognosis, usually in the order of days, and that their goals are solely for comfort, can be given medications to basically make them unconscious until the end of life. And this is a very ethical practice. I would almost argue that it's unethical to not sedate people in this case. It's not done in a way that's trying to shorten their life or hasten their death in any way, but just to help them to be alleviate suffering until the end of life. It's usually done with either very sedating antipsychotics or benzodiazepines. So often things like midazolam and things are used, but other benzodiazepines like lorazepam given by injection could be used as well. There's been some question around, well, isn't this possible that you could be shortening somebody's life by doing this? And there's no real evidence to support that. In some cases, it may be possible, but I think the importance of alleviating suffering as the primary goal is still very ethical. And certainly our intent is not to shorten people's life. And for some patients, I actually would say that this may prolong their life a little bit, because you take somebody that's in severe respiratory distress and make them more comfortable, even though they're not awake, they sometimes can actually live a little bit longer in duration. But so I'm not sure what medications might be available for you in your particular setting. Probably you'd have access to some injectable lorazepam. Is midazolam available at all in the places that you're working, or?
Yeah, midazolam.
Yes, yes.
5 milligram, one vial 5 milligram. Intramuscular is available in government settings in Sri Lanka.
Okay.
And lorazepam IM is intramuscular is it's difficult to get in the government sector.
Okay. And in places like the ICU or something like that, do you have people that are on midazolam infusions kind of continuously, or?
Yes, yes.
Yeah. Okay. Because that would usually be the type of intervention that we would recommend, and would be just a continuous infusion of midazolam, because midazolam is very fast acting benzodiazepine and has strong amnestic properties, so people aren't aware or remembering what's happening, and you can titrate things up fairly quickly to get people comfortable. So we'll have separate sessions devoted to talking about palliative sedation specifically, but it is an important consideration in the management of very end stage dyspnea and terminal distress from dyspnea. So he's now unresponsive, and he looks comfortable to you, but he does have some of these upper airway secretions that you were talking about, and his family is very distressed by these, and says that was his fear of drowning at the end of life, and what else can you do? So we talked about maybe doing some suctioning. Anything else that you might be able to do to help with secretions? Position, yeah, that's important. So either positioning on this.
Chest physio?
Probably not chest physio at this stage, because he's unconscious and very near end of life. So I don't know that would be, but I guess like chest vibration and that kind of stuff, sometimes that people might consider that, but it's more for upper airway secretions. Dr. Vithuran, were you going to say
Supportive
something?
nebulizations?
What kind of nebulizations?
Supportive, something like with ipratropium, steroids.
Yeah, I wouldn't usually think of that helping so much with secretions, but sometimes for people that have really thick secretions that are still more conscious and able to clear them, then we do use things like saline nebulizers just to try to help loosen up the thick secretions, and then they're able to cough it out and clear it a little bit better. The other thing, though, we use for patients that are very near end of life and in the final hours to days of life is things like the anticholinergic medications. So glycopyrrolate or scopolamine or atropine, and these can be used subcutaneously. And obviously anticholinergic effect can be decreasing mucus and saliva secretions. So I don't know which of these you'd have access to where you're working, but glycopyrrolate would be a common one to be used subcutaneously, and then scopolamine or atropine. The other term for scopolamine, I should say, is hyoscine, hyoscine bromide. I don't know if you have that where
Yes.
you are. Yes, okay. So those are all options, and then occasionally suctioning can be helpful if it's near the top, but deep suctioning is pretty uncomfortable for people, so we tend to avoid that close to end of life, and sometimes can cause extra bleeding and distress. And then counseling the family is also very important in terms of helping them understand that it can be a normal part of the dying process, and that people can look comfortable and not have signs of distress, even though they might sound wet and congested. So that's an important piece to remind people of too. So, okay. Any other particular questions about dyspnea right now? We can maybe have some more time after we talk about delirium too to talk about either topic, but any particular questions?
Then, Jonathan, it's a discussion that we need to get the feedback on why these people are. Yeah. And any issues of discussing that?
Yeah.
Yeah.
I just included some questions around what challenges you faced managing dyspnea in patients with advanced disease. If there's considerations about managing things in different settings. I don't know. I think probably most of you are working in hospitals, but I'm not sure if you're trying to manage, patients at home or outside of the hospital. Other challenges you faced.
Actually, I haven't come across any of these cases, but anyway, there is a fear of using morphine. So what is the maximum dose you can go up to in a patient when we are considering to give morphine?
Yeah, that's a good question. What do you think is the maximum dose? Any idea?
No, actually.
No, that's okay. So with opioids, I always think of it as kind of like insulin. There's no maximum dose of medications. With opioids, we always titrate based on benefit and side effects. So basically, you can keep titrating up the dose until you reach some sort of dose limiting side effect. Now, obviously, if you're getting into, very high doses, then you have to start thinking about, is there some other type of medication that might be more helpful, because maybe the benefit of opioid is not going to be a lot more beyond that. But I mean, for patients, particularly with end-stage cancers, like sometimes in Canada, we would have people titrating up to equivalents of even thousands of milligrams of morphine a day, depending on what their needs are. So it's sometimes it can be from 10, but sometimes it's hundreds, and then very few patients, sometimes it's even thousands of milligrams a day that are necessary. So it's very individual. I think it's very important to recognize that we're using this for people with, end stage progressive diseases. So the concern around addiction and dependence and misuse and those types of things is not the same as it is in people with more chronic pain or chronic illnesses that they're going to be living with for many decades. And it is to be alleviating suffering. So to answer your question, there's no maximum dose.
I really showed one of the patient in Halicut, and there was on 200 milligram per day with the giant cell carcinoma lungs, and then the patient was happily cycling, the rickshaw driver, and was working with that high dose of morphine. After that, this problem, our medical school teaching, that most of the time they tell all these side effects of the morphine, and then most of us, when we are coming out of medical school, and this is a big, great difficulty here that overcome that barrier of using. Even then, some of the senior and experienced physicians are still reluctant to use this effect. Really, we need to educate more and train more.
Yeah.
Is it the same thing in Canada also?
I think it's being a lot more accepted in Canada for palliative care kind of situations. We certainly are very aware in Canada of the problems opioids can cause in the non-palliative care settings, and people getting dependent on them over a long time and not having a lot of benefit for chronic pain and things like that. So that has been a concern. But I think it's becoming more open to it being used for end stage illnesses. And I think, the main thing I always try to explain with patients, even sometimes they talk about being concerned about addiction themselves, is that, people with addiction problems, these medications are really harming them and limiting their function and destroying their life. But for people with pain or really difficulty breathing or something like that, we're using these medications to try to help you live better so that you can do more and stay as functional as possible for as long as possible. And there's actually some evidence in palliative care literature for patients with lung cancer that if we help them live better and have better symptom management, that they actually can also live longer as well. So, which makes sense. People are more comfortable, they're more active, and can keep their performance status for longer. So, but it is a challenge around the world, for sure, in terms of access to opioids and prescription of opioids.
And one occasion in our patient, it was mentioned that he's a COPD patient. So anyway, he's having a small respiratory depression. So in this case, will morphine, should we be careful or some extra risk? Are we taking any extra risk of prescribing this?
Yeah, that's a good question. So I think you do need to be cautious, and that's kind of why we talked about starting at lower dose, like 2.5 or 5 milligrams of morphine, just to make sure he tolerates it okay. And certainly if he's in the hospital, then he's well monitored, but these can be started safely at home as well. But I think generally just starting slowly and titrating slowly, it's been shown to be quite safe. Obviously maximizing all the other baseline treatments for management of COPD and dyspnea. So
Excuse me, how frequently we can increase the doses? Because there's a wide range of morphine increasing. So how frequently we can increase the doses?
yeah, I mean, it depends a little bit on the severity and acuity of the symptoms. Like sometimes in the hospital for patients that are presenting with very acute symptoms, we might be increasing the doses every 1 to 2 days, based kind of on what their breakthrough use is. So may start somebody on a regular dose every 4 to 6 hours, and then if they're needing, 3, 4, 5 or more extra doses over the course of the day, then you kind of calculate out what their total dose of the day is, and then divide that out amongst regular doses over the day. In the community setting, I mean, it depends a little bit on how frequently you're following up with the patient and how they're tolerating it. But certainly, every few days to a week, if you were needing to be managing increasing symptoms and they're tolerating it, I think would be safe. But it depends on a lot of factors: the frailty of the patient, where the patient is, how easily you're able to be monitoring things, and that kind of stuff. Well, maybe I'll move on to talking about delirium, and then we can have some time for talking about delirium and any other questions that you might have.
So we have 35 minutes for the breakout rooms to close. So
What was that, sorry?
this is Vinila. We have 35 more minutes for the breakout rooms to close.
Oh, okay. So I'll be fast.
No. It's not like that, but just a reminder.
Okay. Sorry, let me just get delirium up here. Can you see the delirium slides? Yeah? Okay, good. So delirium, I think you all have seen people with delirium. It's very common in medicine in general and very common in palliative care. So it's an important topic to think about. We'll talk about some of the different types and presentations of delirium. And then the big question in palliative care settings is whether the delirium is going to be reversible or not reversible, whether it represents a terminal delirium. And so we'll think about how the management of that differs a little bit, and then some of the non-pharmacological and pharmacological management. So we'll start with a case study again. This will be Mrs. B. She's a 74-year-old woman with known metastatic breast cancer. She lives at home with supportive husband and her son. She's been fairly independent with her daily care needs, but getting a little bit more tired and now sitting and lying most of the day at home, and some ongoing decline over the last months. There's no further treatment options, unfortunately, for her breast cancer, but her family brings her to the hospital because of progressive confusion over the last couple of days, to the point that she's afraid of them and she's calling out during the night and sleeping most of the day. So I guess the first question I'd have for you guys is, does she have a delirium? How do you diagnose a delirium when you're seeing a patient?
By the conversation, so if we ask, we can assess whether she is confused, is she oriented with the time and place.
Yeah.
So
Good.
by that, we can come to the conclusion whether she is really having delirium or not.
Yeah. What are the key components of a delirium, like diagnosing a delirium compared to other types of confusion?
They will be disoriented with time and place.
Yeah.
That's the main key, I think.
Anybody else have any other thoughts or important aspects of differentiating delirium from other causes of confusion?
They don't remember their names and
Yeah. So those types of things are true. They would also be present in somebody with dementia, or psychosis sometimes. How do we differentiate some of those other diagnoses from delirium?
Onset
Onset,
is
yeah. So
onset is abrupt in delirium.
yeah,
Then
so that's an important piece. So it's abrupt onset. So this is the definition, kind of summarizing from the DSM definition. So it's a disturbance of consciousness, which we talked a little bit about. So there's usually a change in the level of consciousness. So people are either drowsy or hyper alert or aroused. There's a change in cognition. So this can be like inattention or aphasia or other types of confusion. Develops over a short period of time. And usually there's some sort of evidence that it's from some sort of medical condition that's underlying. In palliative care, we often divide delirium into three types. There's the hyperactive delirium, where people are very agitated and restless and might be having hallucinations. There's hypoactive delirium, which is most common, but it's also the one that's often misdiagnosed because people may not be so loud, and you may not realize that they're necessarily as confused as they are. And then there's the mixed type that's more fluctuating between both. We know delirium is a very bad prognostic sign. It's very distressing to patients and families. And one of the big problems in palliative care is that it interferes with our ability to assess and treat pretty much every other symptom. When you have a delirious patient, they can't really tell you reliably much else of what's going on. And we know it leads to increased falls and hospitalizations and pressure sores and lots of different types of morbidity. There's lots of risk factors, as we might expect. People that are older age, malnourished, have sensory impairments, more bedbound, people on lots of medications, and people that are being admitted to hospital are all at much higher risk. This is a method of screening for and diagnosing delirium that's used a lot in palliative care settings. Have any of you ever heard of the confusion assessment method? Cam? Maybe just shake your head, or maybe a couple nods to say. So it's a simple algorithm. So people need to have acute onset of mental status changes or a fluctuating course and inattention. So inattention is a hallmark of delirium. And then they need to have one of either disorganized thinking or altered level of consciousness. So we usually test for inattention by things like, having people count backwards, or trying to have them do counting upwards, serial sevens, or things like that. Or sometimes it's just very obvious that they can't pay attention to any one thing for any length of time. It's important to remember the differential diagnosis of delirium, like we talked about. So There's other causes of confusion like dementia or other psychotic disorders. Depression sometimes can present with cognitive features and sense of withdrawal. So important just to think about the acuity of onset of symptoms and if there's any other mood related symptoms. So delirium, there's like dozens, probably hundreds of different causes of delirium. Does anybody have an approach that they use to kind of systematically think about the causes of delirium? Or do you just kind of remember? How do you approach a patient that you're seeing that's delirious in terms of working up what might be the cause? Any ideas?
Doing proper investigations to find out the
Any
cause.
investigations? Yeah.
Something like hyperkalemia, hypokalemia, electrolyte imbalances and everything.
Yeah. Yeah.
Sugar levels.
Yeah. So blood work can be helpful. There's lots of different mnemonics and things, so you can try to remember things as you will. One mnemonic that I just put in here that I sometimes find helpful just to help me go through kind of systematically is the DIMES approach. So drugs, infections, metabolic causes, environmental or structural issues. So drugs, you have to remember both drugs that we start for patients, but also drugs that patients stop taking so they can go into withdrawal and that can cause delirium. Infections, obviously, of various different sorts, many different metabolic issues. Environment is a big one. Any patient that's getting admitted to a loud and crazy hospital environment is at risk of delirium. And then obviously structural issues in the brain itself. In palliative care, we often do add this one as well, retention, for bowel and bladder retention, which can certainly contribute to delirium. So for a patient like Mrs. B, she's got breast cancer, metastatic breast cancer. She's in her 70s. She's coming into the hospital with some confusion at home. What would be common causes of delirium in her kind of presentation?
Brain metastasis.
Yeah, that's important to think about in breast cancer.
Secondaries in the lung and hypoxic stages.
Hypoxic issues, yeah, that's possible. Any other metabolic issues in patients with cancer that are very common to cause delirium? Any patient with cancer that's confused, you should always order several blood tests. Sodium level is very important. Yeah. Any other blood tests?
Sodium.
Calcium, yeah. So calcium hypercalcemia is very common in certain types of cancer, including in breast cancer. And then patients like this, they can often be on medications to treat pain or things like that. So medications are important to think about too. So I just included some of these that I thought could be considered, but as we said, the differential diagnosis of the cause of delirium is often very wide, and in our palliative care patients, it's usually more than one thing that's causing the problem. So you get some further history from her. She's been having some increasing abdominal pain from her cancer, and she's been increasing her morphine. She hasn't had a bowel movement for 5 days. You don't have any particular concerns about infection. Her white count's normal and her CT scan of her head is normal. But you meet her and she's really drowsy. She opens her eyes a little bit to voice, but not oriented. And she's got a little bit of twitching myoclonus. She's dehydrated. and she's got an elevated calcium. So for her, there's at least 5 and probably more contributors to her delirium. How would you manage this situation with her?
First of all, hydrate her and give a proper medication for constipation.
Good. Yeah. So hydrate her, manage the constipation. So she may need an enema, depending on what she can take orally. How do you manage hypercalcemia where you work?
Binding.
What was that? Sorry.
Yeah.
Couldn't quite catch that.
Binding.
Calcium.
Calcium. Yeah.
Calcium. Oh, calcium binding resins.
Yeah.
Okay. What, like that would be taken orally? Or you've given IV?
IV.
IV, okay. Would that be things like bisphosphonates, or what medication would you use? Do you have bisphosphonates? There are things like pamidronate or clodronate, or not sure.
There are some answers in the chat, sir.
Okay.
Calcium binding.
Calcitonin. Okay. IV
Yeah.
gluconate. Okay. Good. Yeah. So calcitonin. That's an option. The challenge with, or the nice thing about calcitonin is that it works very quickly, like within hours to a day. The challenge with calcitonin is that it doesn't last very long, so the body starts to get used to it over a couple of days. So usually we would give people a bisphosphonate, which there's many different types of bisphosphonates that help to draw the calcium into the bones, but they do take several days to actually work. So I'm not sure exactly which bisphosphonates you may have available to use. Some of them can be given IV, some of them have to be given orally, but you can be familiar with what might be available there. And then with opioids, so she does have some signs of opioid toxicity. So hydration can be helpful for that just in of itself, with giving the kidneys more fluids to flush out some of the metabolites that are accumulating. Sometimes we would even try switching to a different opioid if we had a different opioid available. If she'd been on morphine for a while and had some tolerance, we could think about switching to something like a fentanyl patch for her, which is a little bit cleaner and less likely to build up when the kidneys are failing. So we'll come back to her in a minute, but just thinking a little bit more about management of delirium. So like we talked about, the first decision that you have to make in seeing a palliative care patient with delirium is trying to figure out if this is going to be a fixable delirium and they're going to be able to get back to kind of close to where they were before, or if this represents the beginning of the dying process and whether this will be a terminal delirium. And there's often some uncertainty in this. Sometimes we don't really know, but any ideas what indicators might, how might you kind of sort this out clinically in seeing a patient?
If delirium presented with organ failure, multi-organ failure, multi-organ failure could be irreversible, or the terminal delirium.
Yeah, that's certainly one piece. So if you can find specific causes on physical or investigations to treat, It's easiest if there's just one thing you find and then you can fix that one thing. The more factors that you start finding, obviously the harder and harder it might be to be reversing something. The other big piece is kind of the overall trajectory of the patient. If this is their, like, you know, fourth or fifth delirium that's kind of been fluctuating over time and they're otherwise getting more cachectic and declining performance status, it may be more in keeping with terminal delirium. If you see other signs of, you know, the more imminent dying process starting, like people are becoming more mottled or decreasing urine output, those types of things, certainly can be more representing end stage type situations, but it is kind of a global assessment. And then once we think about whether there's a potentially reversible issue, we also have to always think about what the goals of care for the patient are and whether they want these things treated. So some patients just really want to stay at home and to be at home until end of life at home. Other people wanting to come into the hospital to see if there's other things that could be treated. So always going back to what the patient's goals are is extremely important. In terms of managing delirium, what are some non-pharmacological, so non-medication interventions that you're familiar with that are important for managing delirium? Obviously, we'll try to fix the underlying cause of delirium as much as we can, but in terms of actually managing the confusion and the behaviors and all that kind of thing, anybody have any?
Sometimes keeping the patient in a non-noisy beds, the beds without noise and light.
Yeah, so keeping them in a calm environment, I always find having like a window nearby if it's possible, just to have a bit of daylight to keep their day-night cycle as good as possible. Any other ideas from other people in terms of a delirious patient? And
Family support.
Family support, very important, yeah. Frequent relative visits, known person nearby. Seeing some good comments in the chat here. Good, that's all important things. So we'll just go through a few of them here. So sleep hygiene, we often talk about, it's very important. And sleep hygiene just meaning kind of trying to keep people awake and somewhat active during the daytime hours so that they sleep better at night. Having light or bright spaces during the day and then dark spaces at night. Sometimes for patients that are very agitated, having one-on-one observers to be able to, you know, redirect them in their behaviors is very helpful. Often that can end up being family members too, depending on staff availabilities. But it's so much more helpful to have a person that's able to redirect a patient that's delirious, rather than just physically restraining the patient. Certainly there's some cases where physical restraints are necessary for short periods of time for safety and things like that, but overall physical restraints are usually thought to exacerbate delirium and to exacerbate agitation. So we really do try to avoid those. Where possible, avoiding, you know, shall we say, extra tubes and agitating types of procedures for patients, like catheters and IVs and things like that. But sometimes those are important for managing the cause of delirium, so you do have to use them. And then encouraging people to be as mobile as they can be during the day is helpful, so they're not just in bed all the time. We talked about familiar objects and people, and preventing constipation and making sure people aren't retaining lots of urine is really important. Reorienting patients regularly and making sure they have access to some hydration and nutrition as the patient can tolerate. Managing pain if it's present. So this might be with medications or with positioning, with dressing changes for wounds, things like that. And then the other big piece is any sensory aids. So if people have poor hearing or poor vision, that can certainly exacerbate delirium. So helping them have access to their glasses or things like that if they need those. So I think we often, when we think about managing delirium, we think about, as you know, physicians treating the cause, and then if there's a lot of agitation or something, sometimes we have to use medications to manage the agitation. But the non-pharmacological piece of managing delirium is extremely important. It's also extremely time-consuming and is a big challenge sometimes for staffing resources. So that's a big challenge no matter where we are. In terms of thinking about medications to manage delirium, so the first choice usually is with antipsychotics if it's necessary. What factors go into you deciding whether you would choose an antipsychotic? What antipsychotic would you choose and why?
Mainly the agitation associated with the delirium. Usually the agitation is associated with the delirium. We are considering the atypical antipsychotic, low dose of atypical antipsychotic.
Good. What types of atypical antipsychotics would you commonly use?
Olanzapine is commonly we are using olanzapine.
Good. Okay. Anybody else have any other ideas? Olanzapine is very good. What are some of the advantages of using olanzapine?
One other respond in the chat ball is saying risperidone. Tasika is saying risperidone.
Risperidone. Okay. Good. Okay.
Haloperidol.
Haloperidol. I heard, yeah. Any reason that you would use haloperidol versus some of the other ones? Why would people choose different antipsychotics? There's not necessarily one right answer here, so we're just trying to think about what's practical to use to manage some of these agitated behaviors.
Mainly considering the sedation.
Yeah. Yeah. So sedation is a big factor. And the way I think about it usually is, so I organize them in my mind in terms of degree of sedation. The big one in palliative care too is the route of administration that's available, because a lot of our patients, they have difficulty taking things orally. And obviously, if you have a very agitated patient, then sometimes it's difficult to give them something orally. So you have to have something that's more available by injection. And then there's also variability in terms of the duration of action, how quickly things act, and then the risk of extrapyramidal side effects. So that's like the rigidity or tremor and things like that. So it's important to know some of the antipsychotics available near you. We usually divide the antipsychotics into first and second generation, which I'm sure you're familiar with the first generation having a little bit higher EPS risk generally than second generation. The advantage of some of the first generation antipsychotics is that they're more available by the sub-Q, IM, and IV routes in addition to the oral route. So in palliative care, sometimes that can be quite helpful. And then the second generation, which sounds like you're using more of there, which is great, is things like risperidone, olanzapine, quetiapine. They generally have less injectable options. Some of them have depot options for patients with more long-standing psychiatric psychotic disorders. So sometimes they're more difficult if the patient can't swallow. But things like olanzapine, is that a tablet that you're giving people, or do you have the dissolvable form of olanzapine there, or what do you use?
Yeah, unfortunately, the first generation only injection form we have, intramuscular form we have. If it is olanzapine, it's very expensive. It is not in the government setup in our hospitals. Olanzapine and risperidone, and very
Okay.
expensive.
Very expensive.
Chewable is available. Yeah.
Okay. Okay. But I think things like haloperidol would probably be quite commonly available there.
Yes.
Yeah.
Yes.
Okay. Yeah. So things like haloperidol. What kind of doses of haloperidol might you use to manage delirium?
Ten milligram IM.
10 milligram IM. Yeah, for severe agitation. I will say in palliative care patients, so often people with advanced illness are frail, so we tend to start with even much lower doses. So sometimes even like 1 to 2 milligrams, sometimes even for very frail patients, even 0.5 to 1 milligram, depending on the degree of agitation. If they're not necessarily acutely agitated, but they're just having more hallucinations or something, then sometimes, yeah, lower dose haloperidol can be helpful. Do you have any more sedating kind of injectable antipsychotics that you use commonly, or? Dr. J. Arasa was going to say something.
Normally, haloperidol is available. Only haloperidol available in northern province, but in some hospital in Colombo, the risperidone is available.
Okay.
In private sector also it is costly. It's available, but commonly in the northern province hospitals we are using haloperidol. The patient like bipolar, manic and all, we are using average built patient 70 kilogram 10 milligram haloperidol with short acting benzodiazepine. For this one 5 milligram haloperidol, one vial, that is available in our settings.
Okay. And do you give that IM?
IM, yes.
IM, yeah. Okay. Yeah. So that's it's haloperidol is certainly one of the more studied ones and ones with most experience. The challenge with haloperidol is that it is not that sedating on the spectrum of antipsychotics. It has very potent psychotic effects in terms of the dopamine antagonism that it has, so it can be very helpful with paranoia and hallucinations and that kind of thing. But if people are very agitated, it won't necessarily help. You do need a higher dose, I guess what I'm trying to say, to calm them. So but just in people that are more frail or having end stage disease from other issues, I just would be a little bit more cautious with the dosing, maybe starting a little bit lower, because they can develop more of the EPS side effects. And then sometimes people get the extrapyramidal side effects from an antipsychotic, and then it can actually make their delirium a little bit worse too. So just being mindful of that. We talked a little bit about benzodiazepines too. So usually in palliative care, we think of benzodiazepines more in the anxiety spectrum for managing acute anxiety issues and panic and things like that. Usually in palliative care, we are a little bit more hesitant around benzodiazepines in the context of a delirium that we're trying to improve or clear, because we think of them as sometimes worsening confusion. Like they can certainly calm acute agitation, but then people can emerge out of, as the benzodiazepines wearing off, and they can be a little bit more confused. So we do try to stick more with the antipsychotics. But certainly for patients that are more imminently end of life or with terminal delirium, benzodiazepines have a very significant role to manage acute agitation. And things like lorazepam, and we would commonly be using midazolam injectable subcutaneously, like 2 to 5 milligrams subcutaneously for severe agitation, and it's very fast acting to control kind of agitation crises. So Dr. J. Rasa, were you going to say something else, or you look like you were?
Usually from the history, if history suggesting of substance withdrawal or alcohol withdrawal, mainly suggestive of in that part, we are giving benzodiazepine with antipsychotic. If the history is mostly suggestive of the organic causes, we are usually not using this midazolam for the patient with the delirium.
Okay.
Yeah,
Yeah,
but
definitely with alcohol withdrawal, it is important in that case for sure. The other drug I was just going to mention very briefly that's growing use in palliative care settings is dexmedetomidine, and I know they're using this some more in India, but more in palliative care settings with escalating pain towards end of life, and with pain escalating pain medications sometimes contributing to delirium. The use of dexmedetomidine as an infusion can be used to manage severe pain, and actually has had some good case reports of really helping people with delirium towards end of life. This is in Canada, this is a much more expensive medication. I think it's more available in India because they have some production facilities there, but that's just to include as kind of a growing area of interest in palliative care. So with Mrs. B, you give her some fluids and bisphosphonate and haloperidol and bowel care, pain management. You're able to discharge her home, but she remains very weak, and her cognition has improved since her admission. A month goes by and her family calls you with similar complaints, again, that she's getting more confused and agitated, and she's now very cachectic and bedbound, but they don't want to come back to the hospital, and they want to be able to support her at home until she dies at home. And I think they're recognizing that this is more of a terminal delirium type of situation. How would you support them through this kind of situation? Looks like we have 2 minutes left. Okay. Oops.
let her to die peacefully at home, to sedate her with some benzodiazepines.
Yeah, so it's important to educate the family about terminal delirium, and that it can be a normal part of dying, but that it's important to manage the symptoms. Having some sort of subcutaneous or sublingual medication available for them, so whether that's haloperidol or subcutaneous lorazepam or midazolam or something like that, would be important to have available. I think we're pretty much at the end of our session, but any other last minute questions about delirium?
I have a question that you mentioned the reversible and irreversible delirium. How challengeful maintaining the patient in the community level while detecting and managing the patient?
How, sorry, do we maintain the patient in the community?
Yeah, if you have the community level, the reversible or reversible patterns, it is difficult to do without investigation. So how
Yeah,
we are going to
it depends on what kind of investigations might be available in the community. I mean, you could try to look for causes that may not require investigations, like medications that were changed or constipation or
Sorry, sir. Please go ahead. I think we all are back. Sorry.
oh,
Please go ahead.
good. Okay. Good, everybody. I guess we have a couple minutes left. Thanks for joining us for this session, and I hope that the nursing session was helpful for those involved there. And was there any last minute questions or anything like that people had about these topics?
Thank you, Dr. Jonathan. It was very useful session for us.
Okay.
Thank you. Thank you so much.
Well, your feedback is always very, very important for us, and we try to keep these things interactive with cases and things like that. So please fill out your feedback and let us know how we can improve sessions moving forward.
Stella, ma'am, you, how about you? Sorry, have you finished your session?
Yeah.
Oh.
We have finished the session. They had a lot of questions, and everything is done now.
Thank you, ma'am.
And today's session was really interactive session because
Wow,
they had
great.
a lot of questions. Okay, yeah, they have interacted.
Thank you, ma'am. So I have shared the feedback link in the chat box, requesting all the participants to fill the feedback without fail. And I mean, before we wind up, I have a small announcement saying that like the next session will be on 26th May. It's again from 3 to 5 p.m. I think, Jonathan said, do you have something to say about the timings? Because Dr. Suren had to leave, he texted me.
Yeah, looks like most of the respondents to Krishna's survey have wanted it more in the evening, the 7 to 9 p.m. time. So I think we may try to look at moving it to later, but we'll have to have a bit of discussion as faculty about whether that's possible and whether the faculty on Wednesday can shift to later. So we'll send out some emails to confirm timing for Wednesday.
Sure, sir.
Okay.
I think last batch about 7 to 8 participants couldn't join the sessions.
Okay. And I understand that the COVID situation is becoming a lot more challenging in Sri Lanka and obviously in India as well, but that puts a lot of pressure on people being able to attend. So thank you all so much for attending this evening, and it's really, really helpful for you to be part of all these sessions, and the interaction piece is so important. So.
Yes, madam, please. Yes, ma'am. And thank you so much, Dr. Jonathan and Stella, ma'am, for giving your valuable time and reaching out to our participants. Today's sessions, I think, I felt really it was very interactive, even the doctor session compared to the previous sessions. Thank you so much, one and all. I know it's a Saturday evening, weekend. You must be very busy with your families. And please just spare 1 minute of your time to fill out the feedback. See you on 26 May, Wednesday, 3 p.m. Thank you so much.
Thank you.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you. Thank you. Thank you very much. Thank you. Thank you very much.
Thank you.
చదువుకోకుండా చదువుకుంటాం అనుకుంటున్నాను. ఇయర్ఫోన్స్ పెట్టుకొని అయ్యుండొచ్చు. బాగా ఎక్కువ పెట్టుకొని వినడానికి పెట్టుకొని మళ్ళీ ఎందుకంటే నాది ఎందుకు ఇప్పుడు స్టార్ట్ అయిందంటే బ్యాగ్స్ వేసుకున్న తర్వాత, ఎందుకంటే